Week 3, Group 2, a presentation on atrial fibrillation by Kilala Asanyan and Janelda Rosario, Lisa Hansen, and Marie Angeline Lim. A 48-year-old male with a history of diabetes and hypertension presented to the emergency room department with new onset palpitations. He first noticed the palpitations 5 hours earlier while at his desk, and he had never previously experienced these symptoms. He denied chest pain, shortness of breath, leg pain, and edema. He said he also became dizzy before going to the emergency room, but has been generally weak for the past 4 days. His temperature was 37.8 degrees Celsius. He had an elevated heart rate of 148 and an elevated blood pressure of 157 over 79. His O2 saturation was 99% on room air. On exam, he had no evidence of acute decompensated heart failure. The initial ECG revealed atrial fibrillation with rapid ventricular response. The patient also reported smoking 1 pack of cigarettes and drinking 3 alcoholic drinks a day. The patient has no known allergies and is currently taking lisinopril, carvedilol, Xanax, and Novolin. In addition to his vital signs, the patient's heart rate was irregular and had a respiratory rate of 20, with no crackles upon auscultation. He also had a BMI of above 30. Atrial fibrillation was first described as auricular fibrillation by William Harvey in 1628. Now it is commonly known as AFib. AFib is one of the most common types of cardiac arrhythmias, which are irregular heart rhythms. AFib causes the heart to beat much faster than normal. Also, the heart's upper and lower chambers do not work together as they should. When this happens, the lower chambers do not fill completely or pump enough blood to the lungs and body. Hence, causing a dissociation between peripheral pulse and heartbeat. This irregular and rapid heart rate causes poor blood flow. This can make a patient feel tired or dizzy, or they may notice heart palpitations or chest pain. Blood also pools in the heart, which increases the risk of forming clots and can lead to strokes or other complications. An irregular pulse is reflective of abnormal conduction. Risk factors: age, family history and genetics, lifestyle, heart disease or other medical conditions, gender, and a history of surgery can all raise one's risk of developing the structural and electrical anomalies that cause AFib. Even a healthy heart, a fast or slow heart rate from exercising or sleeping, for example, can trigger AFib. Cardiac diseases like myocardial infarction and congestive heart failure can be risk factors for AFib. Non-cardiac risk factors like smoking, drinking alcohol, hypertension, diabetes, and obesity can also cause AFib. The patient's age puts him at a higher risk since risk increases with age. His gender also puts him at 1.5 times higher than women to get AFib. Also, the patient has the non-cardiac risk factors above that altogether put him at a higher risk of getting AFib. Signs and symptoms of AFib: general fatigue or weakness, and fluttering palpitations or thumping in the chest are the most common symptoms reported by patients. A rapid and irregular heartbeat, shortness of breath and anxiety, faintness, confusion, dizziness, sweating, chest pain or pressure, and an elevated blood pressure. Sometimes people with AFib have no symptoms and the condition is only detectable upon physical examination. Our patient presented to the emergency room due to palpitations. He reported weakness and dizziness. He also had an irregular heartbeat, tachycardia, and elevated blood pressure.
Pathophysiology. The heart is made up of 4 chambers in which blood flows. Blood flows to the right atrium, then to the right ventricle. The right ventricle pumps blood to the lungs to become oxygenated. Oxygenated blood returns to the heart through the pulmonary veins in the left atrium and then flows into the left ventricle to pump blood back to the aorta to distribute blood to the rest of the body. Atrial fibrillation arises from abnormal electrical impulse formation from a structural trigger like atrial dilation, hypertrophy, inflammation, and fibrosis from clinical cases like hypertension, coronary artery disease, heart failure, and valvular disorders. Damage to cardiac tissue generates abnormal and irregular electrical impulses. The atrioventricular AV node normally functions to control the electrical signaling of impulses in the heart. The movement of electrical impulses causes the heart to contract, thereby sending blood to the rest of the heart and body. A compromised AV node becomes less effective at controlling what electrical impulses are sent to the ventricles, causing an elevated ventricular rate. The abnormal impulses result in a quivering type of contraction that is unable to adequately empty the atria, resulting in blood pooling and an insufficient blood volume being ejected. This results in the potential for clot formation and embolization. Over time, the atria can become enlarged and lead to permanent atrial fibrillation in adults. There are several classifications for atrial fibrillation. Paroxysmal is less than or greater to 7 days, persistent greater than or equal to 7 days, long persistent greater than or equal to 12 months, or permanent. Pathophysiology for presenting case. The patient is both exhibiting physical signs and has a medical history, which predisposes him to be at risk for atrial fibrillation, as described in the previous slide for the case presentation and risk factors. Physical signs and symptoms presented by the patient include a history of diabetes and hypertension, new onset palpitations, becoming dizzy and generally weak, an elevated heart rate, having diabetes type 2 for 15 years, being a smoker and smoking 1 pack of cigarettes a day, and having 3 alcoholic drinks a day. The initial ECG at presentation also revealed that the patient is experiencing atrial fibrillation with rapid ventricular response and has an irregular PR interval. Hypertension and alcohol intake are especially triggers for structural changes in the heart causing atrial fibrillation. Hypertension causes left ventricular hypertrophy and left atrial remodeling, which increases the risk for atrial fibrillation. Excessive alcohol intake increases risk for AFib since the patient drinks 3 alcoholic drinks per day. Alcohol has been found to trigger AFib by inducing electrical atrial remodeling, thereby increasing excitability of electrical impulses and creating arrhythmias. Heavy and habitual consumption of alcohol promotes higher rates of progression from paroxysmal to persistent atrial fibrillation.
Diagnosis includes history and physical, EKG, which uses electrodes to sense and record electrical signals as they travel through the heart. This is the primary tool for diagnosing atrial fibrillation. Echocardiogram is used to diagnose structural heart disease or blood clots in the heart. Blood tests such as electrolytes, renal panel, hepatic analysis, thyroid panel, and CBC are essential to enable the physician to rule out other diseases such as electrolyte imbalances, thyroid problems, or other substances in the blood which causes the atrial fibrillation. Telemetry monitoring and Holter monitoring may also be done. Holter monitoring records the heart's activity, usually for 24 hours or longer, which enables the physician to assess heart rhythms over a period of time. Other diagnostics include stress tests, chest x-rays, which reveal pulmonary disease or cardiac disease. Treatment. The main goal of treatment is to reset the rhythm or control the rate, and to prevent blood clots causing stroke. Resetting the heart rhythm includes electrical cardioversion, in which an electrical shock is delivered to the heart to reset the heart's rhythm. Antiarrhythmic medications include beta blockers, which can help slow down the heart rate. Cardiac glycosides, such as digoxin, or calcium channel blockers, which control heart rate, but needs to be avoided for patients with heart failure or low blood pressure. Pacemakers and implantable cardioverter defibrillators may also be done. Surgical procedures include catheter ablation, in which a catheter is inserted through the groin and is guided through blood vessels to the heart. The tip produces extreme cold or heat to destroy areas of heart tissue that is causing the irregular heartbeats. May's procedure is when the physician creates a pattern of scar tissue to interfere with straight electrical impulses. Atrioventricular node ablation is done if other ablations are unsuccessful. It is often accompanied with pacemaker placement to keep the ventricles beating properly. Blood thinners are essential since AFib causes patients to have high risk for blood clots. These medications are often taken lifelong due to the risk of stroke. Anticoagulants include warfarin, which is one of the anticoagulants given to AFib patients, but requires frequent blood work to monitor the PT and INR, as these patients are high risk for bleeding. Newer anticoagulants are shorter-acting blood thinners, but does not require frequent blood tests. This includes the dabigatran, rivaroxaban, apixaban, and edoxaban. Aspirin combined with clopidogrel is not as effective, but is another option. In our case, our patient needs lifestyle changes such as alcohol cessation, weight loss, and smoking cessation.
The harshest outcomes of atrial fibrillation are stroke, hospitalization, and unfortunately sometimes even death. However, it is also very possible to live a long and healthy life with AFib. This requires lifelong medical management, including use of beta blockers, blood thinners, calcium channel blockers, or other heart rhythm medications that keep the heartbeat more regular. Also important is treating the underlying disease processes for better outcomes. The combination of heart failure and AFib, for example, increases risk of death from AFib. Making lifestyle modifications will also improve and support outcomes. For this case, the patient will have better outcomes if he stops smoking and drinking and has his blood pressure and diabetes well controlled. If these are all true, he can have positive outcomes and live a healthy life even with AFib. With AFib, it is so important to learn to manage your condition. For this case, the 48-year-old man needs to learn how to care for himself and how to monitor his condition. If he has had an ablation, he needs to keep regular follow-up visits with his provider. Keeping his diabetes and blood pressure under control will be key. One way to influence both of these is by using the DASH diet. The diet is made up of a high percentage of fruits and vegetables, along with lean proteins. This diet has been shown to lower blood pressure, weight, and help control blood sugars very quickly. Our patient can also consult the American Heart Association website to get ideas for exercise plans and recommendations for how long and how often to exercise. Aerobic exercise is good for heart health, and it only takes a minimum of 20 minutes a day to make a difference in cardiac activity. Of course, smoking cessation education is also important, along with information about cutting back or discontinuing the use of alcohol. Medications for AFib as well as smoking cessation should be considered for this patient, and proper education needs to be given about daily use of these drugs. Monitoring the use and signs and symptoms to watch for while on heart rhythm and blood thinning drugs is vital. For our 48-year-old diagnosed with atrial fibrillation, life is about to change. He may have invasive procedures performed to help correct the rhythm of his heart, or he could be put on medication, or both. These drugs will either be beta blockers or calcium channel blockers, which control the rhythm, or they will be blood thinners such as warfarin to keep his blood from clotting and reduce his risk of stroke. He can still live a full life. He needs to keep his underlying conditions managed, including his elevated blood pressure and his diabetes. With education about the best diet and exercise plans, he can start losing weight and see both the blood pressure and blood sugar numbers decrease. He will also receive education about smoking cessation and reducing alcohol use. All of these are additional risk factors for AFib. With regular visits with his provider to monitor the health of his heart and his medications, he can continue to live a healthy life.
Thank you for taking the time to watch our presentation.